Hi, this is Tom Lüscher and Inside Cardiology. Today we discuss the pandemic that really is the biggest challenge for healthcare in current times. But let's first look back on how medicine developed. On this very slide you see on the left how the tree of medicine grew more and more into different specialties. While initially we had internal medicine as an overarching specialty, we now have, as you can see, endocrinology, nephrology, cardiology, neurology, rheumatology. We have oncology, we have pneumology, and we have gastroenterology. And of course this was necessary because of the fantastic development of diagnostic and therapeutic options. Medicine had to specialize, and specialized doctors indeed provide better service because they have the experience, the caseload, and therefore provide the optimal care. But even in cardiology it went further. As you can see on the right hand side, we have even subspecialization in one of the largest fields of medicine, that is cardiovascular medicine. We have, as you can see, people that are colleagues that primarily focus on imaging, others on pharmacotherapy and heart failure in particular, others treat arrhythmias with ever more sophisticated procedures. Then we have valve interventions that became more and more catheter-based for TAVI, MitraClip, and now TriClip. And we have, of course, coronary intervention since Andreas Grünzig's seminal procedure in 1977. But now we face a bigger problem that needs systems cardiology, I would argue, and this is cardiometabolic medicine. So let's see what it actually is. In the old days, we were hunters and gatherers. We had to hunt 7-8 hours per day, otherwise there was no dinner, and we were slim, and we admired gods that were well fed. Today, it's the other way around. We are getting bigger and bigger, and we admire those who stay slim. This pandemic of obesity is a huge challenge for medicine, because it affects many other diseases as well, as we will see. But let's first look at the epidemiology. This is from the ESC consensus paper on obesity, and you can see that particularly in North Africa, Turkey, there is a huge prevalence of obesity in the adult population. Over 30% of the adults are obese. In Europe, most of the countries, as you can see with the color coding, have an obesity rate of 20 to 25% roughly. The best countries in terms of body weight are Italy, Switzerland, and Denmark. So there's huge heterogeneity of obesity across countries in Europe at large, but the problem is worldwide. So let's look at what this implicates. Here you can see what are the causes of this pandemic. Obviously, it is by physics increased energy intake and less energy expenditure. And you can see the energy intake is related to high caloric soft drinks, high caloric tasty food, all you can eat, unlimited availability of food, contrary to when we were hunters and gatherers, and we cannot cope with it. Particularly because also our energy expenditure has decreased. It's a complete automation of life. We take cars, we have remote controls for anything, for the garage, in the kitchen, for the TV, and we use less energy. But there are factors that are important here. They're neurobiological factors. In fact, research says obesity is really a disease because some people have a different set point of satiety in their midbrain, and therefore there is a genetic predisposition to acquire obesity in an affluent environment that we live in today. And of course, there are socioeconomic status factors and psychological factors as well. But it all leads to something that is really integrating all organs, and here you see what the consequences are. So the increase in body weight affects, for instance, the liver. There is fatty liver disease that may even develop into cirrhosis. There's increased blood pressure as we increase body weight. There is increased insulin resistance, decreased insulin sensitivity. There's an alteration of glucose metabolism. There is renal dysfunction, reduction in glomerular filtration rate, albuminuria. There is changes in the microbiome, dysbiosis, that is a new cardiovascular risk factor because the bacteria, they eat what we ingest and they digest what we ingest. And so forth, glucose metabolism is dysregulated also by changes in the pancreas. And importantly, we have adipocytes and visceral fat that changes its phenotype and becomes inflammatory in nature. And here you can see it on the very top right, that innate immunity is activated under these conditions. The macrophage infiltration in the body fat, particularly the visceral fat. This leads to cytokine release, such as interleukins and tumor necrosis factor alpha, among many others, and the generalized inflammation throughout the body. And this affects all these different organs that I mentioned earlier, but importantly, it affects the heart that's in the middle here. In cardiometabolic medicine, the heart is the center focus because all these dysregulations of metabolism in all these organs eventually focuses in to the heart with heart failure, myocardial infarction, stroke, and premature death. And what can we do about it? Of course, that's also the integration of these different dysfunctions in organs. The fact that many of these drugs indeed have effects in the liver, in the kidney, in the heart, in the pancreas, and the visceral fat. So we have antihypertensives as we had it for decades. We might consider renal denervation. We have now also siRNAs for angiotensinogen. We have statins that work in the liver, and we have PCSK9 inhibitors as well. And of course, we have insulin and metformin for insulin resistance and insulin supply. Then we have these sodium glucose transport inhibitors and the new mineralocorticoid receptor antagonists that are non-steroidal in nature. And then we have also, at the level of the pancreas, we have GLP-1s, GIP, and insulin, as well as for the visceral fat, and again, the sodium glucose transport inhibitors. So many of these drugs that we have now, they are actually cardiometabolic drugs, if you wish. The sodium glucose transport type 2 inhibitors, as well as the GLP-1s, the glucagon-like peptide 1 agonists, as well as the GIPs, combined drugs. So with this, we have an integration of different fields, and therefore we need a doctor that really knows about using those in a comprehensive manner. Now here it's again shown that over a lifetime we increase body weight today already in childhood, which is a really big concern we have. Then of course as an adult many are obese, as I showed earlier. They develop dyslipidemias, they develop high blood pressure, diabetes, fatty liver disease, renal dysfunction, either of those in different combinations and different phenotypes that eventually zoom into the heart, where it induces HFpEF, HFrEF, as well as myocardial infarction, stroke, and premature death. So I would argue that we need to learn treat these patients in a very integrative manner, involving different subspecialties and knowledge thereof, to use diet, exercise, pills, and the syringes, the injectables. The diets usually work very little. They work for 6 months, and at 12 months usually the effect size is lost. But still we recommend Mediterranean diet, because beyond changes in body weight, this has been shown to be protective. Exercise works to some degree. In randomized trial, reduction in body weight is in the range of 2 to 3 kilograms, but it is overall protective for the cardiovascular system. Pills are now available for oral medication for GLP-1 application. These are new drugs that are a little bit less effective than the syringes, the injectables, that provide very good levels of GLP-1, and the newer ones like the GLP-1 GIP molecules that have to be injected on a weekly basis. So these are the treatments, and this is the knowledge a cardiometabolic cardiologist, the new generalist if you wish, providing systems cardiology to the epidemic, the pandemic of today's time. And that eventually involves, as I show here on my last slide, knowledge about obesity, knowledge on how to treat diabetes with GLP-1s and sodium glucose transport inhibitors, knowledge about the microbiome and how nutrition affects it, knowledge about renal function, and be conscious that GFR is a major cardiovascular risk factor. Lipids are easily integrated in cardiology already today, endocrinology and hypertension as well. So this is really what we envisage as a new generalized specialty of cardiovascular medicine, that is cardiometabolic medicine. And this brings us again together after the immense and impressive specialization that we envisaged as from internal medicine to all these subspecialties that now have to work together in a way to the benefit of our patients. So thank you for attending.